Thanks, Nicole, and thanks for the kind introduction. And hello to everyone out there. There'll be a pretty interactive session today. Both Katie and I will go through some slides and talk about diagnosis of HHT, and I'll touch on diagnosis of some of the other elements associated with HHT as well. But please do type in any questions into the chat box. I'll try to answer those whenever I'm not speaking. And we'll also have Nicole to kind of funnel questions to us at the end. So hopefully any questions you have, we might be able to answer. Some interesting poll results here. So genetic testing and clinical diagnosis, I thought would probably be the majority, but together that's only about 40%. And pretty high percentage are either self-diagnosed or none of the above apply. So it's interesting. I think what I personally see at my center is that patients often go undiagnosed for a long, long time, sometimes well into their adult life, and they've seen multiple doctors and still no one really makes the diagnosis of HHT until eventually they hopefully either run into a physician that's more knowledgeable, or they make the diagnosis themselves. And then the diagnosis is often confirmed, of course, with genetics. So pretty interesting findings there. We're splitting the topics up a little bit today. Katie is a certified genetic counselor, has a much better understanding of the genetic elements of HHT diagnosis. She will cover all of that, and I'll cover more of the clinical side and touch on some of the AVM diagnosis as well. So I think we'll go ahead and get started and kick this off. So some very basics. I mean, we all know HHT, also known as Osler-Weber-Rondeau. That's actually what the Brits know it as, and because Osler was a British guy. In Germany, it was Weber-Osler-Rondeau because Weber was German, and in France, it was Rondeau-Osler-Weber because Rondeau was French. So they always picked whichever nationality was first, was based on what country it was in. So finally, everyone got together and just decided to call it HHT. And it's a genetic disorder of blood vessel formation. Incidence somewhere around 1 in 5,000 to 1 in 7,000. It affects all backgrounds, all races and creeds, and it's an autosomal dominant genetic mutation that does not skip generations. And Katie will go more into that. The clinical criteria that I use in my clinic are based on some criteria that were presented originally at a conference in Curacao. And these are the 4 criteria: spontaneous and recurrent nosebleeds, telangiectasias, which are the small red or purple spots in characteristic locations, arteriovenous malformations, which are malformed vessels that often occur in the lungs, brain, or liver, and then also a first-degree family member with HHT. First degree meaning a brother, a sister, a parent, a child, someone who's closely related having a diagnosis of HHT. And if you only carry 0 or 1 of these criteria, it's pretty unlikely that you have HHT. If you have 2 of the 4, it's possible or probable that you have HHT. And if you have 3 or 4 of the criteria, you definitely have HHT. So we use that very frequently to make the diagnosis. And before about the year 2000, when genetic testing wasn't done very much, it was the predominant way of making the diagnosis. But nowadays, of course, we have genetics to confirm this. There are definitely limitations of the clinical diagnosis. Certainly in children and young adults, it can be really unreliable because most kids don't really show many signs of HHT. Or sometimes the signs are confusing because nosebleeds in kids are very common, even among normal kids. And so it's hard to tell a normal child with nosebleeds from an HHT child with nosebleeds. Certainly the nosebleeds tend to get more severe as patients get older, usually starting in childhood in HHT patients. But the telangiectasias usually don't appear until the 20s or 30s age range. And so if you have a child presenting to the HHT clinic, it's often very difficult to make a diagnosis of HHT, and we really rely on the genetics in those scenarios. And there's also quite a few patients who have 2 of the 4 criteria, which puts them in this possible or probable category. And so we really need the genetic testing to help sort those patients out and figure out who truly has HHT. I'll let Katie cover the mutations that cause HHT. We see endoglin and ALK1 as the most common ones, and we certainly kind of follow a pretty familiar testing regimen. That's that we'll test the index patient, whoever presents to the clinic that has definite HHT, we'll test them to find out what the mutation is. And once we've identified that mutation, we can test for that mutation in all of the at-risk family members by testing just for that one mutation, because the mutation is going to be the same for everyone in that family. There are a few limitations of the genetic diagnosis that I'll let Katie get into, but suffice it to say that not everyone we can detect a mutation, and there's hundreds of mutations that can cause HHT. They're predominantly in these 2 or 3 genes, but there are a few kind of outliers that don't fall into those categories. And fortunately, over the last 20 years or so, there's been a real increase in the centers of excellence throughout North America. When I started the UCLA Center in 2010, we were the 10th center in the US, or rather in North America, and now we're upwards of 20 and upwards of 25 even centers throughout the nation. So we opened ours about 11 years ago and have about 600 or so patients that come to us, especially from Southern California, but also Nevada, Arizona, Alaska, Hawaii, et cetera. And so lots of patients that I see in my clinic, and some patients come to see me and other patients come to see my very handsome colleague, Gary Duckweiler, who is a neurointerventional radiologist and is my co-director at the center. As with every center of excellence, it's really a nice place to get your HHT care because there's a full multidisciplinary team of doctors who are familiar with HHT and know how to treat the various issues that can arise. So certainly we have a center cardiologist and GI doctor and ENT doctors, dermatologists, and so on, because there's so many different organ systems that are affected by HHT. And this is similar at pretty much any center you go to. Would highly recommend that anyone who has either suspected or definite HHT visit a HHT center of excellence at least once to make sure you're on the right path with your care. We often, since I'm treating patients that are outside of Los Angeles, we're often collaborating with your physicians back home so that you don't have to come and see us every time you need to have any HHT care. But it's certainly helpful to at least make that contact so that your doctors and you will have a point of contact for any of your questions and issues that come up. So what kind of things do we see with HHT, and how do we make this diagnosis clinically? This is a look at what the typical telangiectasias look like. And what these are, they look like little red spots, but if you look at them microscopically, it's actually a little tiny shunt between a tiny little artery and a tiny little vein. And that shunt is dilated or kind of distended and forms this red spot. And so there's actually quite a bit of blood flow happening in these telangiectasias. And that's why I'm sure, as many of you have seen, these can bleed quite aggressively, kind of like an arterial pulsatile flow when they bleed. And that's why nosebleeds are sometimes gushing. And some people have telangiectasias like this on the fingertips that will actually, shoot blood out of their fingertips, and similar on the lips and tongue, which are the characteristic locations of these telangiectasias. And if you look inside the nose, it's basically the same thing that's causing the nosebleeds, are these little red spots. They're very fragile, and the movement of dry air through the nose can cause these to rupture and bleed, and that's the cause of the nosebleeds in HHT. And similarly with GI bleeding, they can happen anywhere along the intestinal tract, all the way from the mouth to the rectum and anywhere in between. And so you can have this kind of slow or persistent GI bleeding, or in some cases even severe GI bleeding, especially as patients get older. And so we certainly manage a lot of patients with those issues. And then the second kind of main category of abnormalities with HHT are these larger arteriovenous malformations, which are kind of like a telangiectasia, but on a much larger scale. These are still a direct connection between an artery and a vein, but instead of being a tiny 1 or 2 millimeter spot, these are a larger connection. And on this picture that you can see in the lower right, this is actually out in the lung. This is an angiogram image, and we've actually selected out a little artery of the lung, and we inject contrast dye, and you can actually see the contrast dye passing into a dilated nidus, or kind of the core of the AVM, and then it drains directly into a pulmonary vein. And this is abnormal. Normally, the lung would have kind of tapering little tiny fine branches like you see elsewhere on this angiogram, like here, that doesn't have this direct connection with the pulmonary vein. And by eliminating the capillary network that normally is here and is filtering out the blood clots and bacteria, without that capillary network, a blood clot or bacteria can pass right through this artery to vein connection and end up causing a problem like a stroke or a brain abscess, etc. And the similar kind of physiology is happening in the lung as it is in the liver and the brain, which are the 3 main areas where these AVMs occur. So to kind of summarize the abnormalities that we see in HHT and how often we see them with HHT, well, nose, we almost always, 95% of patients with HHT will have telangiectasias in the nose. And this would be a typical appearance, this kind of red spots. They can be very variable, often are pretty diffuse throughout the inside of the nasal cavity. This is actually a look at the inside of a nasal cavity. The skin, also very common as patients get older. Telangiectasias usually show up in their 20s or 30s with these little red spots on the lips, on the tongue, on the fingertips, sometimes on the ears, sometimes on the toes. And those are very characteristic and typical. Small little red spots elsewhere in the body, like on the arms or on the chest, are not so characteristic of HHT and do occur in normal people just with sun exposure. So usually we're looking for them in these characteristic locations. And then as far as ones that we only diagnose with imaging, that would include liver, brain, and lung. This is a brain MRI scan, and there's a little AVM, this little black thing here is an abnormal network of vessels that's a brain AVM. That occurs in about 10% of HHT patients, depending on the genetic subtype. Liver AVMs are actually quite common. Around 50% of HHT patients have liver AVMs. Most of the time they cause no problems, but occasionally they can cause increased flow through the liver and end up resulting in high output heart failure. So as you get older, if you have a lot of liver AVMs, we keep track of your echocardiograms to keep an eye on your heart function. And then I treat a lot of patients with lung AVMs. About 30 or 40% of HHT patients will have a AVM in the lung, like I just shown you. And here's an example of a angiogram of the lung showing all the little branches of the lung. These are all normal branches with the exception of this one branch down at the base, where you can see this branch, instead of tapering to a fine little point where it's going to the capillaries, is instead connecting through this big vessel directly into a pulmonary vein. And so that's what we see with lung AVMs. And then on the GI side, as I mentioned in the intestines, around 30% or so of HHT patients as they get older will have telangiectasias in the intestines that can cause slow bleeding and chronic anemia. Just a closer look at some of the skin telangiectasias. If you're self-diagnosing or helping diagnose family members, this is what you might see. Little red spots on the lips, little spots like this on the tongue. A little hard to see because these pictures are kind of small, but you can see these small little red spots on the fingertips, so very characteristic. Usually those increase in number with age. They can bleed recurrently, and if so, they sometimes are treated with laser, with excision, or with sclerotherapy. Nosebleeds, as we know, is a huge problem in HHT, will be the topic of a different webinar because it is such a big topic. Thankfully, the treatments for nosebleeds have improved over the years, and we're able to control these, though not eliminate them in most of our patients. And of course, this is a big, big issue and can result in anemia, transfusion dependence, and of course, difficulty with at work or social situations. And so we certainly, a big part of my practice is trying to help my HHT patients with their nosebleeds. And what we see inside the nose, here's just a different picture of a nasal endoscopy. So when they put the little camera into the nose, you can actually see these red spots inside the nasal cavity. You can imagine how these are very thin walled. The movement of dry air across these telangiectasias can cause them to be kind of cracked and rupture, and you can get quite pronounced bleeding. And other things that can cause bleeding, as many have seen, would be high blood pressure, excessive straining, or even bending over. In the intestines, there's a similar appearance of the telangiectasias along the intestinal wall. This is from an endoscopy of the intestines, and this is just a close-up of the stomach wall where there's a little red spot, which is a telangiectasia, and these can be prone to bleeding just like in the nose. And that bleeding tends to occur in more advanced years, beyond 50 and 60. Most of the time it's in the stomach and small intestine, but can happen in the colon as well. They can be diagnosed with endoscopy, and usually it's not gushing bleeding like you can sometimes have from the nose. It's usually more of a slow, persistent bleeding that over weeks and months can cause chronic anemia. And often it is not even noticed by patients. They just find that their doctor checks them, or they're feeling tired and their hemoglobin is, you know, half of what it should be, maybe a 6 or a 7 instead of having a normal hemoglobin of 12. And so that's a common presentation of the GI bleeding. Sometimes it is noticeable. You might see blood in the stool or in the toilet bowl, or you may have black or tarry stools, which is called melena, and that's basically digested blood that you can see in the stool. And then symptomatically, you can have fatigue and look pale from the anemia. And we won't get too much into testing and treatment of GI bleeding, but it can be pretty easily tested for with a fecal occult blood test. And the CBC will often show iron deficiency anemia, and then endoscopy to confirm it. I mentioned kind of already the lung AVMs. This is just a schematic of what a lung AVM looks like with a feeding artery, a nidus or sac, and then a draining vein. And you can easily see how a little clot or bacteria could pass right through this connection and end up causing a problem. Aside from causing strokes and brain abscess, it's also bypassing the capillaries, which are the network where oxygenation occurs. And so the oxygen levels are often low in patients who have multiple or large lung AVMs. But it's not a great way to diagnose pulmonary AVMs on its own, because even if you have lung AVMs, your oxygen may be totally normal because much of your lung is normal. So just looking at an oxygen saturation is usually not sufficient to make the diagnosis. That's why we do screening with bubble echo or lung CT. They tend to be congenital, so usually are present at birth, but can grow over the course of childhood and even can enlarge in size over adulthood. And by the time we're doing our screening, about 30 or 40% of patients with HHT have a lung AVM. And conversely, if we find a lung AVM, most of the time it's associated with HHT. The clinical importance of these we mentioned in brief, and that's that often you'll be short of breath because of low oxygen in the blood, because it's actually reducing your lungs' ability to oxygenate the blood, because that blood is basically bypassing the capillaries. And then because there's no capillary network to act as a filter, the clot or bacteria can cause a TIA or a stroke or a brain abscess. And over a lifetime, these are the percentages that you might expect this type of problem to occur. So we expect that at 1 or 2% per year. And so depends on the size and number of lung AVMs, but on average, it's something that you could very often see over the course of your life. Migraine headaches also very common with HHT and lung AVMs because of these vasoactive substances that pass through these lung AVMs. So those are quite frequent and often improve when we treat the lung AVM. People worry, of course, about bleeding, and they can rupture, these lung AVMs, especially the large ones, but it's a little bit less common, around 10%. Pregnancy does more often lead to rupture because of the increase in blood volume, as well as distensibility of the AVMs increasing with some of the hormones of pregnancy. So certainly if you have any consideration of being pregnant, everyone should be screened for lung AVMs, but particularly if someone is looking to become pregnant, they should be screened and treated for lung AVMs beforehand. Or if they haven't been screened or treated beforehand, they should be screened and treated even during pregnancy to avoid this problem, which usually happens in the 2nd or 3rd trimester. This is just a picture of what a bubble echo looks like. This is basically what we do to diagnose lung AVMs without even having to use x-rays or radiation. They insert an IV. They use agitated saline to create bubbles, and they inject those bubbles while watching with an ultrasound over the heart. And this is what that ultrasound picture looks like. And it's a little bit hard to, this looks like snow kind of, but this is the heart here, and you're seeing the 4 chambers of the heart. Here's the right ventricle and right atrium, left ventricle. And so the bubbles should basically come back to the right side of the heart, but you should not see bubbles on the left side of the heart because they should be getting filtered out by the lungs. So when you start seeing bubbles like these little tiny white specks in the left ventricle, left side of the heart, that means there's a shunt somewhere. And so this is actually a positive, mildly positive bubble study. When we see that, then we do a CAT scan and try to locate the AVM. This is what a CAT scan looks like. These are cross sections basically through the chest, and the spine is here and the ribs coming around, the heart in the middle, and then all the vessels of the lung kind of radiating out from the center. And here is an abnormal vessel leading to a lung AVM. And you can see this little abnormal vessel that's too big and connected between an artery and a vein. So that's what a lung AVM looks like on chest CT. And I treat a lot of those with a minimally invasive procedure. We go in with a tiny catheter and block it off. So I won't go into that in detail. This is kind of the subject of a whole nother lecture, but it's a very safe procedure where we can take care of these with an outpatient procedure, placing coils or plugs into that abnormal vessel and immediately protecting you from the problems from stroke and bleeding and brain abscess. And we actually see the oxygen level go up on the table as we're doing this procedure and blocking off the AVM. They'll go from 90% to 95 or 99% just as we're blocking it off. So it's really immediate improvement. And our goal is to include all of these AVMs that are big enough to treat. There's just an angiogram of what a lung AVM looks like. So this is our little catheter coming up from the femoral access. And this is the right lung. And you can see all of the normal vessels of the lung, and then one abnormal vessel with an artery and a draining vein. That's the AVM. We enter it with our catheter, pass a little tiny microcatheter all the way to the nidus, to the sac, and coil it or plug it to block it off completely. And now you can see when we inject contrast, there's nothing passing through, and we've occluded that AVM and treated it successfully. So right away, patients will feel better and will no longer be at risk of those problems. On the brain AVM side, there's just a zoomed in image. This is a brain MR. And so this is the brain tissue here. The gray matter is actually a little bit lighter gray, and the white matter on this particular sequence is actually a little bit darker. And then this black is what we call flow void. This is actually blood vessels. And so this is a tangle of blood vessels within the brain, and that's what a brain AVM looks like. And when we shoot an angiogram of that, this is coming up from below in the carotid artery, dividing into all of the branches leading to the brain. And one of those branches is clearly very abnormal with this abnormal network. And this is this same brain AVM visualized on an angiogram with a big draining vein. And so those have a propensity to rupture and cause brain bleeding. And that's why we look for these and treat them oftentimes if we see it. The typical presentation is with bleeding, though it can be with seizure or headache as well. Thankfully, the risk is not as high as it is in the general population who have brain AVMs. If you have an HHT brain AVM, it seems to be around 1% per year risk of bleeding. And if it's a smaller AVM, less than 1 centimeter, it's even lower risk and oftentimes low enough risk that it may not need treatment. So that's on a patient-to-patient basis and would be based on consultation with a neurosurgeon and neuroradiologist. But in general, the smaller the AVM, the lower the risk. We're actually studying that with a longitudinal study, which some of you may be part of, watching to see how patients do with brain AVMs. We screen for brain AVMs with brain MR, and we do that during childhood, and then we do it again at age 18. If you have a negative brain MRI at the time you're 18 or any time after, you don't have to be rescreened any time after that, because new brain AVMs do not occur after age of 18. So if you don't have one by 18, you'll never have one. And so that's a nice thing about brain MR. Unlike with lung AVMs, where there's a small chance a lung AVM could grow over the course of time and might show up later in life, if you don't have a brain MR by 18, you never will. And CT can be used if MR is not possible. Some people cannot have MR for a variety of reasons. The last little thing I'll touch on is liver AVMs, which are quite common, especially in females with HHT, and tend to be diagnosed in older patients. This is just what a liver looks like at surgery, and here's some of the abnormal blood vessels from HHT. And on a CAT scan, these white areas are all the abnormal vessels. There's a lot of abnormal vessels throughout the lungs, and it's causing enlargement of the IVC, which is the big vein carrying blood back to the heart. And so all this flow can sometimes lead to so much flow happening, it's making the heart work harder and end up running into heart failure problems as you get older. And so for patients that have liver AVMs, most patients do fine, but we will keep an eye on them with an echocardiogram to screen and check their heart function every couple of years. And we can diagnose the liver AVMs directly with ultrasound or CT or MRI. Most times, patients don't need treatment for these liver AVMs. They'll usually live with them their entire life and never have to have anything done. Do want to make sure you don't get a liver biopsy of one of these. So some doctors are not as knowledgeable about HHT. Make sure you speak to your HHT physician if anyone is asking to biopsy your liver, because they may be biopsying an AVM, which of course could lead to bleeding. I mentioned some of the complications that can occur, and the most common being heart problems, but sometimes you can have liver problems as well related to these. So we won't go into management today. There's just too much to cover. But in general, you know, when you go to a center with HHT expertise, like these centers of excellence, their general goals will be to try to control your symptoms and improve any bleeding that you're having, treat your anemia, screen for and treat any AVMs you might have, thanks to these multidisciplinary network of doctors that are present at the centers. And then if there are any complications related to any of these problems, like liver failure or heart failure, we can help treat that as well. So that brings my part of the presentation to an end. And I believe we're saving questions for the end. So I'll go ahead and kick it over to Katie for a discussion of the genetics component. So I'll unshare here.
Thank you so much, Dr. McWilliams. And so Katie, while you bring up your presentation, we'll launch our second poll. And this has two questions. Have you or a family member received genetic testing, yes or no? And if you have received genetic testing, what gene has been identified in your family? Endoglin, ACVRL1, or ALK1, or SMAD4, or other? Okay, we're going to close the poll and share our results. So Katie, here's who's in the audience today.
Great, thanks, Nicole. I will talk a little bit about the different types of the different genes that can cause HHT and kind of talk through some genetic testing scenarios to get you thinking about how does the genetic testing affect your family and who should be tested in the family. So it's helpful to know who has had some genetic testing and how people have received their diagnosis and what genes you all have genetic changes in. So I'm going to go ahead and get started and start thinking about some genetic testing scenarios, like I mentioned. So because this is a guidelines talk, I really want to focus and talk a little bit about what the guidelines are for managing HHT and think a little bit about how they apply to genetic testing. So as I go along in my talk, you will see me just bringing up the different guidelines and how they apply and maybe explain a little bit about why they're written this way. So I'm going to be focusing on the guidelines that are related to genetic testing. So I've highlighted those in blue. So thinking about, Dr. McWilliams, of course, talked about how to make a clinical diagnosis of HHT, but we can also make a diagnosis by identifying a causative mutation that you would find on genetic testing. So talking a little bit through that. Thinking about how asymptomatic children of a parent with HHT should be considered to have possible HHT unless we can exclude them by genetic testing and what that means and how we can do that. Talking just about how clinicians should refer patients for diagnostic genetic testing for HHT. And then thinking about for people who test negative for specific genetic changes in some of the genes that you all mentioned you have changes in, kind of where you should go from there and what that means for your family. So I think Dr. McWilliams touched on this a little bit, but we have the Curaçao diagnostic criteria and we have genetic testing, and sometimes people are asking us, why should I use the Curaçao criteria or why should I use genetic testing? And so when we think about it, if you do have symptoms of HHT, you could very well be diagnosed with the Curaçao criteria that Dr. McWilliams went through, and you may not need genetic testing for yourself for your own management. And I will throw in the caveat that might be with the exception of SMAD4, and I'll just mention what some of those things are a little bit later on in the presentation. If you don't have symptoms of HHT, but you have a family history, Dr. McWilliams talked a little bit about this, but we know for some people, if you're too young to show some of the symptoms that are age-related, you may not know that you have any symptoms, but you still have HHT. Could be that you don't have any of the more visible symptoms yet. If you haven't been fully screened, then you might have Avms in the liver, the lungs, or the brain, and just not realize that because you haven't had any screening. And we've had lots of people tell us that, when we ask them in clinic, do you have nosebleeds? They'll say, oh no, nothing compared to my dad or my sister. And that's because those people in their family have really significant symptoms. But when we start asking our patient, well, how often do you have nosebleeds? They'll say, well, it's just once a week. It's not every day, or if it's not multiple times a day. So sometimes patients just don't realize that their symptoms are more than what we would expect in the general population. And so that's when genetic testing can really come in handy. If someone doesn't meet those Curaçao criteria or are completely asymptomatic at some point in their lives. And so that's where that first guideline comes into play, that identification of a causative mutation on genetic testing can really help to figure out who needs additional HHT screening in the family. So I'm just going to mention briefly some of the genes that were on the poll. So ANG and ACVRL1 are certainly the most common causes of HHT. SMAD4 accounts for about 3 to 5% of cases of HHT. And I mentioned before that there's some additional management that might go into patients who have this mutation. And that's because SMAD4 can cause not only HHT, but also juvenile polyposis syndrome, which causes an increased risk of polyps in the stomach and the GI tract, in the colon, and causes an increased risk of cancer in those areas. And then we've also know that there are some connective tissue symptoms that can be seen with SMAD4 mutations. And many of those that are documented are really related to stretching out of of different blood vessels causing aneurysms, not Avms, in different places in the body, including around the heart. So if you have a mutation in SMAD4, in addition to HHT, you really need to be screened for these other conditions and symptoms. I'm just going to briefly mention GDF2. It seems to be a really, really rare cause of HHT. And then about 10 to 15% of patients, we're not able to identify their underlying genetic cause of HHT. There might be a few reasons for that we still need to look into a little bit more. So it could be that there's another condition that overlaps with HHT quite a bit called Capillary Malformation Arteriovenous Malformation Syndrome, or CM-AVM. And that's caused by changes in RASA1 and FB4. And so if you haven't had genetic testing for those, that might be something to consider exploring. We can have intronic changes, which are parts of the gene that traditionally haven't been analyzed on genetic testing, but there are some labs that look at some intronic changes now. And genetics is becoming more savvy, and more labs are starting to look at these areas of genes that we previously didn't know how to interpret. And then there is something called Mosaicism, which I won't get into a ton, but Mosaicism is something where it may not be detected on blood or maybe even on a saliva sample. And so it's possible when we're doing genetic testing that we're missing some of those mosaic changes. And again, genetic technology is improving. And I think in the hopefully near future, within the next 5 years, we'll be able to test for a lot more of these intronic and mosaic changes kind of on routine genetic testing that we can't do right now. And so the fifth guideline that I already mentioned talks about, what gene should we be tested for if you have HHT? And really, ANG and ACVRL1 you should be tested for. And if those are negative, then you should definitely consider testing for SMAD4 as well. In practice, what I would say is most labs offer all 6 of these genes that are on this panel at the same time. So depending on who's ordering your genetic testing or depending on some insurance issues, if you undergo genetic testing for HHT today, it's quite possible you'll be tested for all 6 of these genes. But if you're not, then you want to make sure that you're tested for at least ANG and ACVRL1. And if those are negative, then you would want to follow up with SMAD4 testing. So I just want to go through some basics and some scenarios to think about genetic testing and how that relates to diagnosing people in a family. So I'm just going to walk through the different types of results that we can get and what that means for people. So Dr. McWilliams mentioned that we really want to start genetic testing with a person in the family who has HHT. But I told you, if you know you have HHT, you might not need genetic testing for your own management. And that's true. You might not need it for your own management, but it can be really helpful for your family members if you have a genetic diagnosis. So I just want to talk about positive, negative, and uncertain results and how that affects family members. So if someone who we know has HHT has positive genetic testing results, then we know that we can test their family members definitively. And really, any family member, their parents, their siblings, their children, more extended family members. And that's because if we have a positive result, we know the genetic cause of their HHT, we know what the spelling mistake is and what gene it's located in, and then we can test their family members for that specific change. And if those family members test negative for that specific change, regardless of what symptoms they have, then we know they don't have HHT and they don't need extra screening. And so that's when we're able to exclude people based on genetic testing from needing any further screening for HHT. On the other hand, if you have a person with HHT who's had positive genetic testing and you test their family member and their family member has positive genetic testing, you know for sure that that person has HHT. And there are additional screening recommendations that Dr. McWilliams went through that that person now should follow, even if they have no symptoms yet, even if they're a child with no symptoms. I'm going to jump over and talk about uncertain results. So an uncertain result is when you get a spelling mistake in one of the genes that causes HHT, but unfortunately there's not enough information in the scientific community yet to determine, does it definitely cause HHT or is it just normal variation in your DNA? We can have lots of changes in our DNA that don't actually cause any genetic conditions. And so because, Dr. McWilliams talked about that, there are hundreds of different types of mutations that can occur in the HHT genes, we don't understand or know all of those different changes, and we don't know how they affect the blood vessels. So if a result comes back as uncertain, it can be a lot more difficult to know who in the family has HHT. So with an uncertain result, you might be able to test other people in the family for that same genetic change, and that might help you figure out whether or not that genetic change tracks with HHT in the family. And it might help to eventually reclassify the result. So reclassify means that the lab is able to say then with certainty, yes, this genetic change does cause HHT, or no, it definitely doesn't cause HHT. But that can sometimes take years to work out, either because it takes a long time to test family members, or because we still just need additional information, testing of thousands of people to see who else might have this genetic change, how common the genetic change is, or studies on whether or not that genetic change causes any changes to the blood vessels. So you might be able to test other family members to try and figure that out. But in the meantime, it goes back to that guideline about asymptomatic children of a person with HHT should be screened. So anyone who has a parent with HHT, if you have an uncertain result, you're not able to use that genetic testing to figure out, do they have HHT or not? And so really, until they're able to be excluded by genetic testing at some point, you have to treat them as though they have HHT. And so people in this situation are likely going to need screening. Thinking about negative results, if a person with HHT has negative genetic testing, then we know that they fall into that 10 to 15% of families where we're not able to identify the genetic cause. And so that means we really cannot use genetic testing to help identify other people in the family who might have HHT. We would expect if the person with HHT that we know for certain in the family has had negative genetic testing, we'd expect any other family members to have negative genetic testing as well, even if they had HHT. So again, this is a situation where you really need to treat everyone who has a parent with HHT as though they have HHT or possible HHT and screen them appropriately. So a lot of people ask us though, well, what if I can't test someone in the family who has HHT first? Because maybe it's insurance reasons, or maybe that person's not available anymore. Maybe that person's not interested in genetic testing because it's not going to change management for them. So let's talk through a couple of those scenarios. So what happens when we're starting testing in the family with someone who's asymptomatic or whose diagnosis is uncertain? So we can get the same types of results, positive, negative, or uncertain, but it can be more tricky to interpret sometimes. So a positive result, even in a person who's asymptomatic, is really clear. Positive genetic testing result means that that person has HHT, that we can screen their children or test their children because each of their children have a 50% chance of having HHT, and that person needs screening for HHT. We would expect that their parent who has a diagnosis of HHT, they would have that same genetic change that was found in them. We have an uncertain result. We're kind of in the same boat as we were before, where we might be able to test other family members to figure out, is this change really causing HHT in the family or not? But it can sometimes take a long time for that to happen. You could test the asymptomatic person's parent who has HHT to see if they have the variant, and that might help to clarify some things. But again, it may not be enough information to reclassify that result. So we would still say that this asymptomatic person, if they have an uncertain result, they would still need screening for HHT. And then what happens with a negative result? So a person who's asymptomatic but has a family history of HHT has a negative genetic testing result. Well, it really depends on what their parent's result would have been. Would their parent have had positive or negative genetic testing? And so just knowing that the asymptomatic person is negative doesn't tell us what their HHT status is, unfortunately. So again, thinking back to the asymptomatic person's parent, if they had positive genetic testing results, then the asymptomatic patient or child who already had negative genetic testing results, that tells us they don't have HHT and they don't need screening for HHT. But if that parent with HHT had negative test results, as I mentioned again, 10 to 15% of people with HHT have negative genetic testing, then that asymptomatic child could still have HHT because they also had negative genetic testing. And we can't use those genetic testing results to help determine whether or not they have HHT, and that child still needs screening. So what I really want to get across is genetic testing is complicated, and that leads us to the fourth guideline that talks about clinicians referring patients for diagnostic genetic testing for HHT. So if you're having genetic testing ordered for you for HHT, the person who's ordering the testing should be able to tell you what genes are being tested. So we talked about how that's a guideline about what types of genes need to be tested. They should be able to talk to you about the type of technology that's being used and talk a little bit about, whether or not any of those intronic or mosaic changes might be expected to be able to be found. They should be able to talk to you about who is the best person in your family to test based on the symptoms and the family history that you've given. And they should be able to talk to you about how to interpret the results based on who might be available to do the genetic testing on and what those results would mean. They should also be able to answer questions for you about insurance coverage and cost. Cost of genetic testing has been coming down in recent years, but can really vary depending on the institution that you're being seen at and the laboratory that's used. And then the last thing I just want to point out is that the person ordering your genetic testing should be able to answer any questions you have about how genetic testing results might impact health or life insurance coverage. And then just thinking about what other things might you need if you are thinking about having genetic testing done. So if anyone in your family has had a positive genetic test, then asking them to get a copy of that genetic test and bringing that with you to your appointment or sending it ahead to your appointment can be really helpful. And just knowing with certainty how that person is related to you. Cure HHT has a My HHT Diagnostic Care checklist that works through some of these scenarios that I've been talking about. So you can go to the website and look at this checklist and go through what are some of the questions that you should be asking yourself, how or when might it be appropriate to do genetic testing, and what are some of the things you need to gather in order to do that. And then what are your options for actually getting genetic testing done? So certainly HHT Centers of Excellence are going to be able to help you coordinate genetic testing. You could also see a genetics provider really anywhere throughout the country. So you could see a genetic counselor or a geneticist. And if you're wanting to find a genetic counselor closer to you, nsgc.org has a Find a Counselor option on their homepage. And so you can go there and put in your city or zip code and try and see, where's the closest genetic counselor to you. And then there are some telehealth or telegenetic options now. Genome Medical is a company that has physicians and genetic counselors on staff that can order genetic testing for you via a telehealth appointment. Informed DNA has trained genetic counselors who can provide genetic counseling to you and talk through the different genetic testing options, and usually works with a primary care provider or a specialist that you've already seen to help order the genetic testing. And there are lots of telehealth options, telegenetic options that are becoming available all the time. So these are just a couple of examples. So that's kind of the nuts and bolts of what I wanted to talk about. And I want to leave at least a little bit of time for some additional questions. So I'm going to hand things back over to Nicole so that she can tell us what some of the questions are.
Great. So thank you so much, both Katie and Dr. McWilliams. We really appreciate that overview of clinical and genetic diagnosis, which is obviously very important in HHT. So I know that Dr. McWilliams has answered a couple of questions in the Q&A directly. If anybody has any other questions, feel free to put them in there. But we did have several people that provided us questions as part of their registration. So this individual, her name is Jenny, has 3 sisters that have been diagnosed with HHT. At this time, she's not showing any signs. However, she's concerned that she might still have it and it's just not visible. So she's saying that her sister's been recommended to get genetic testing, and she's wondering, is that the best option, or should she go through the clinical screening process?
So I think genetic testing can often be the most definitive if your symptoms are uncertain. So if her sister has symptoms, I'm sorry, Nicole, is that what you said? If her
Yes.
sister has symptoms and has been recommended for genetic testing, if her sister's results are positive, then she could have genetic testing for just that one genetic change that was found in her sister. And so then if her genetic testing's negative, then she doesn't have HHT, couldn't pass it on to any children, and doesn't need any of the screening for HHT, which can often be more invasive than genetic testing. We usually do genetic testing on like a saliva sample or a blood sample.
Okay, very good. So our next question comes from Susan, and she's asking if her grandson, whose age is 15, and has some spots on his face that the dermatologist has told them might be HHT. He also has nosebleeds. She's wondering if he should go to an HHT center, and would he need a doctor's referral in order to do that? And as it turns out, her husband does go to Augusta, so should her grandson go to the same location?
Yeah, that is the best way to go. So if you're the family member of someone who has definite HHT, and whether or not you carry signs of HHT, in this case, the child does have some signs of HHT, nosebleeds and some red spots, definitely should be evaluated at a center of excellence, preferably the same center that's seeing the family member so that they have all those records available. And usually the best way to proceed will be to do the genetic testing on the person with the known HHT, so the father in this case, and then test the child for the mutation. But even in the absence of genetic testing, we can usually make the diagnosis clinically and do the necessary screening. So yeah, kind of the short answer is definitely go to a center, and preferably the center where the family member is being seen.
Great, thank you. So Heidi from our audience is asking, when getting genetic testing, is it good to bring a test result from a third cousin? Is that helpful, or is it too far out in the family tree? Her dad and his brother and sister have not been formally diagnosed.
I think if there's been someone in the family who has a positive genetic test result and you have access to that you should bring it. But again, knowing how that person is related to you, and hopefully knowing some of the family history as far as, what symptoms maybe people who you're related through, what they have, will be helpful. Because, not everyone who has HHT wants to go through testing, and not everyone has to. So once the mutation's been identified in the family, like Dr. McWilliams was talking about during his talk, everyone in that family will have that same mutation. And so unless by some random chance you have HHT symptoms on the other side of your family, that genetic cause from your third cousin would be the same in you if you had HHT.
Okay, great. Thank you so much. So we have a question from Anne, and her daughter and one of her daughter's two children tested positive. The second child tested negative, but that child is now 18 years old. It's been 5.5 years, and that person is developing small telangiectasias in a few areas, and is wondering if that granddaughter should be retested.
Generally, I would say that genetic testing is very accurate in diagnosing HHT when the family mutation is known. If you're having concerns about any symptoms, then I would suggest going to talk to someone who's knowledgeable about HHT at an HHT center. There are unfortunately mistakes that can happen with genetic testing. Very rarely, labs have processes in place where that's not to prevent those, but anytime you have humans involved in something, there could be error. So rarely there could be a sample mix-up or a mix-up with the report. That is very, very unlikely. But if people have concerns, then making sure to double check, making sure that there is no abnormalities in the way that the genetic testing was handled, it wouldn't hurt to double check. But in general, if that person had negative genetic testing, even if it was 5 years ago, it would be very unlikely that they had HHT, maybe a 1 in 10,000 chance that they could have HHT related not to their family history.
Okay, great. Thank you. So we have a question, well, really more of a statement from Benjamin, who's on live with us. And he's saying that his Kaiser genetic counselor said that if you have a relative with HHT confirmed by genetic test, Invitae will test all relatives at no cost. I know you're familiar, probably both of you, with that testing. I know there are certain parameters around that. Would you want to talk to that just a little bit?
So some labs do offer free family testing within a certain period of time after the original family member's test comes back positive. Usually it's around 90 days, but with COVID, some of that has been extended to about 150 to 160 days in some cases. So the genetic testing itself can be free. Sometimes what is confusing is that you still need someone to order the genetic testing for you. And sometimes someone like a primary care provider might not feel comfortable doing that. So you often still need to see an HHT Center of Excellence or a genetics provider to help you coordinate that testing and make sure you're tested for the correct family mutation.
Great, thank you. And so we have a question from Amy. And so her family mutation has been determined through genetic testing. And she's wondering the best way for her to get tested and wondering, does she need to send her blood sample to a particular lab, like the one where maybe a relative was tested, or does she just need to know the mutation and send it to any lab?
So in general, I like to send to the same lab when I can, but sometimes due to insurance or cost, that's not possible. So definitely knowing what the family mutation is and having a copy of the result is the most important. And then whoever's ordering the genetic testing for you should be able to either send to the same lab or to identify and talk with the lab that they're going to send it to make sure that they could identify that family mutation. So again, I'd really recommend an HHT Center of Excellence or some type of genetics professional if you don't have an HHT Center of Excellence close to you to help you get that genetic testing done.
Okay, thank you. So Paulin, who's on live with us, this is kind of an interesting question because he's from Mexico. His dad was recently clinically diagnosed. He doesn't have symptoms himself, but they live in different cities. So he's wondering what's the best approach for him to get diagnosed or to confirm that he does not have HHT. And I know that's tricky because we don't have HHT centers in Mexico at this time.
Yeah, we still would recommend kind of the same workflow that if at all possible, having the father who has known HHT get the genetic test would be the best way, and then get mutation specific genetic testing, meaning if once the mutation is back, then you yourself could be tested for that mutation. That would be the most definitive. If that's not possible, then going to either a center of excellence, which may be tough in Mexico, or at least an academic center in Mexico that might have some knowledge of HHT, to see a physician there who could try to make the clinical diagnosis. But it would be preferable to do it genetically because it would be the most definitive.
Thank you very much for that. So our next question is asking, and I don't know if either of you have experience with this, but does testing positive for HHT lead to insurance discrimination?
So in the United States, for health insurance, there is federal protection against using genetic test results for determining health coverage or premiums. That doesn't apply to life insurance. So life insurance companies can ask you if you've had genetic testing, and they can use that to decide whether or not to offer you a policy or what your coverage might be. Life insurance companies are becoming, I think, more savvy. So understanding that people who have some genetic conditions who undergo the appropriate screening are certainly less risk than a person who has a genetic diagnosis, who hasn't had any screening and who isn't followed for that. So I can't say, one way or the other if genetic testing results will impact whether or not you're able to obtain life insurance coverage, but it might be something that comes up. It might change your premiums. There might be some companies that don't ask about genetic testing at all. So I think it's just something to be aware of. Sometimes we tell people, if you're going to go through genetic testing, then you might want to think about, do you have the life insurance coverage that you want? But I would be really thinking about that more for people who are asymptomatic, where the genetic test result really is the only sign that you have HHT. If you have symptoms of HHT, that's going to come up on life insurance health screening questions, and you're going to have to answer those questions. You can't, ignore the symptoms that you already have, and it's probably your symptoms that would impact your life insurance coverage options more than just the genetic test results at that point.
Okay, great. Thank you so much. So we have come to our hour, but I am going to ask just last two questions. One is, I think, geared towards Dr. McWilliams. Do people with the same mutation have similar symptoms or problems within a family?
Yeah, it's kind of surprising that they usually don't. So patients who have HHT within the same family often have very different presentations, despite them all carrying the same mutation causing the HHT. So there's not a lot of overlap of symptoms. You could have one family member that has a lot of nosebleeds and no AVMs, and another family member who has no nosebleeds but has multiple AVMs, and they have the same exact mutation. So the only way they could, there is some similarity because at least they would have the same gene mutation, meaning it would be either indiglin or ALK1 or so on. And indiglin tends to have more lung and brain AVMs, and ALK1 tends to have more liver and GI involvement. And so there's a little bit of influence on what kind of presentation you'll have, but in general, there can be wide differences even within the same family.
Okay, great. Thank you. And so our last question is actually geared towards, I'll combine sort of three into one. They're asking if HHT center doctors consult with local physicians. So if someone were to travel to a center but then goes back home, would you consult with them? And how should they persuade their doctor to actually use the guideline recommendations?
So yeah, it's something I do all the time. Communicating with patients' local doctors is just a part of being a center director. And so certainly I think you can expect that your doctors can communicate about HHT. And as far as getting the referral, usually you can just ask. Any reasonable physician will be happy to put in that referral. But if for some reason they're resistant, you could take the guidelines right off of the Cure HHT website that state that every patient with HHT should be seen at a center of excellence if possible, and kind of just ask that they go ahead and put that referral in. And if they still refuse, you might consider getting a different primary doctor, because I think that's pretty unreasonable if they don't.
Yeah, we would agree. At the Cure HHT office, that's always our first line. We say if you can just get there once, at least then you've been screened and you're a patient of record. And if there are questions that arise back home, you have somebody to consult with or ask your doctor to consult with that has the knowledge. So definitely the best recommendation. So I just, again, want to thank Katie and Dr. McWilliams for joining us tonight and to answering all these questions and giving us such a thorough overview of clinical and genetic diagnosis for HHT. So on behalf of everyone at Cure HHT, I want to thank you for attending tonight's webinar and staying connected with us. We are here for you as a foundation, and we are the only patient advocacy organization funding HHT research, providing educational materials to both patients and providers, and advocating for the disease and expanding treatments around the world. So we're grateful tonight for the speakers that we've had and for the McMahon family, their commitment to pay it forward so that future generations have more effective treatments and ultimately a cure for HHT. Because without their financial support, the Guidelines Conference would not have been possible. And I just want to remind you that if you haven't received your complimentary copy of the Comprehensive Guide to Managing Your HHT, let us know by completing the short survey that'll pop up on your screen at the end of this webinar. This is only one topic in the International HHT Guidelines Education Series. We have covered 8 other topics, and those have been recorded and are available on our website at www.curehht.org. And lastly, I just want to remind everyone that June is HHT Awareness Month. Yesterday was the kickoff event for the Foundation's 30th anniversary, which is huge. And so just keep visiting our website and social media channels for updates on other anniversary events that will be going on all year long. Again, I want to thank Dr. McWilliams and Katie Wusik for their volunteering their time tonight. This program has been recorded and will be posted on our website. We truly appreciate your participation, and I hope you enjoy the rest of your evening. Good night, everyone.